Yeah,
Thank you
go
very,
ahead.
very much. I'll just share my slides. So I hope you can all see that.
Yeah,
So
I
thank
can see.
you. Brilliant. Thank you so much for having me. So my name's Anna. I'm a speech and language therapist at the National Hospital for Neurology and Neurosurgery, which is part of UCLH. And I work in the memory disorders clinic, in the cognitive disorders clinic, seeing people with language as part of their speech, language and communication difficulties as part of their dementia. I'm also a researcher and a lecturer at UCL. And I'm going to talk a little bit today about the role of the speech and language therapist and the research that underpins that work that we do with people with dementia. I wanted to start, however, by really flagging the breadth of communication difficulties. And I've used this figure from some work done by over in the States at Northwestern by the multidisciplinary team there. And they developed a care pathway for people with different types of dementia. And they broadly categorized people into dementias which have an amnestic or a memory-led presentation, or dementias where the person has a behavior or emotional-led syndrome, and people who have a visuospatial or language-led syndrome. And they've provided us with a really useful synthesis of how a lot of the clinical work we have done in speech and language therapy from across the disciplines we work with can be applied to people with all these different types of dementias. However, what I'm going to do is I'm going to really focus on language today in this talk. I've been asked to really focus in on word finding difficulties in particular. And I want to flag this because this is actually one of the, in fact, the most common reason that people with dementia are referred to speech and language therapists in the UK. We know from speech and language therapists across the UK that when they receive referrals, this is the most common thing that comes up. The second most common thing being swallowing difficulties. But actually, I wanted to start this talk by flagging that we have a role across the different types of dementias, because all of these areas, memory, behavior, visuospatial, and language, they all impact on communication and interaction. However, I'm going to focus on language. And I'm going to draw your attention, first of all, and I know Professor Garrett has so beautifully talked about language in the dementias, but I'm going to paint a very broad brushstroke to show where we fit. So dementia is, of course, an umbrella term that encompasses all these four major and many more types of dementias. And I'm going to really flag there's, of course, these more typical types of dementias within these groups. So, for example, in Alzheimer's, we have the more typical memory-led Alzheimer's. We have the rarer atypical posterior cortical atrophy, which we were just talking about, and the logopenic. Then we've got this similarly with frontotemporal dementia. We have the more common and perhaps the less common, or the more typical and the less typical. We've got different types of Lewy body dementias, different types of vascular dementias. In fact, there are hundreds of other dementias. But if we're specifically talking about language, these are the three where language is the primary, the leading symptom. So these three types of dementia often are subsumed under the category primary progressive aphasias. And they are, of course, as I've illustrated here, associated with these two main pathologies, with the Alzheimer's pathology in the case of logopenic aphasia or logopenic variant PPA, and with frontotemporal dementia, most commonly in the case of semantic and PNFA. However, we do now know, as Professor Garrett was alluding to, or it clearly highlighted, that there are lots of other dementias where progressive aphasia may be a secondary syndrome or secondary symptoms. So, for example, in behavioral variant frontotemporal dementia, I often get referrals to see these clients because they're developing problems with either with articulation, so something closer to an NF, a non-fluent variant, although also I often see people presenting with frank semantic issues. Of course, in Parkinson's disease, people present with language impairments, but also executive difficulties impacting on communication. And as we were just discussing, people with PCA and typical Alzheimer's will develop language difficulties. And in my experience, having worked with these people, and particularly very recently, I've been doing some work with people with PCA, people have often talked about this being one of the second most difficult symptoms to live with after their primary visual symptoms in posterior cortical atrophy. And often these are a group where, because they can't read or they can't write or they can't see their environment, this group are often depending on their language in order to manage in their day-to-day life. So I wanted to illustrate with this slide the huge importance that language can play in the lives of people with all different types of dementia, and actually the contribution that speech and language therapists can make towards assessing and differentially diagnosing these dementias. However, I'm going to talk a bit more about on therapy, and I'm going to talk a bit about the model of how we deliver therapy interventions. I've spoken about these different diagnoses, but I also wanted to emphasize that when we as speech and language therapists see people with dementias, we may see people at different phases of the disease. I've just chosen this image to illustrate that there are phases. There's no particular reason I've got 3 there, but I guess we often use mild and moderate, more severe to describe all of our clients with dementia. And speech and language therapists can have a very important role at any of these stages. And I'm often spoken to by referrers who suggest that maybe we only have a role at the very milder stage. But actually, I would emphasize as a clinician that I believe, and I know from the research evidence, that I can have a role at all stages of a person's journey with dementia. What I would say is I would take a different approach. So for example, at the milder stages, I might work more directly with the person, working more on exercises, where at the more severe end of the journey, I might be working with the people around the person and looking at the environment. So I may take a different approach, but I certainly would feel I would have a role to work with these people. And of course, I would take this role I would assess this role based on what the situation requires. It's very rare that people come to me and they say, I want to speak to you because I've got Alzheimer's. They come because they say, what can I do to help my wife? They say, I just want to keep my job going. Sometimes the people with the younger onset, or I love reading to my grandchildren. How can I keep doing that? Or I really want to go to the pub. I want to maintain some of these functional interactions, but other people don't understand, or I'm so lonely and frustrated. So these are the things that people come to me and say, rather than that they have a diagnosis. So how do I work with them? So I've started off by categorizing the therapies that we do, and I've started doing that verbally already, into 3 categories. I often talk to people about exercises, so more impairment-based interventions that aim to restore or maintain, actually, when we're talking about language and dementia, some of these access to words. We also talk about aids, so compensatory measures that help a person get around the problem. In speech and language therapy, we might use more high-tech aids or more low-tech aids, but I've just mentioned before, we also look at the environment. We look at the people around the person, and often that's the direct immediate spouse or partner or immediate family members. So I'm going to tell you a little bit about the evidence to underpin these interventions, and I'm going to start by talking about practice. And a lot of this evidence that I'm describing comes from this group of primary progressive aphasias, which are an extreme phenotype, but which we know can allow us to translate into the work we do into other types of dementia. It has applicability across the dementias. And in this type of therapy, what we would do is we would support people to practice a subset of words, and we would look at how we need to practice those words. So for example, naming pictures, and we might look at either the word meanings or the word sounds to maintain their ability to access the semantics or the lexical word form or the articulation of that word. We know, however, that in order to achieve this goal of maintaining these words, we need to select words that are personally relevant and meaningful. We need to start early. That's where we know the most benefit comes from. And this is an intervention. If it was a medicine, I say to my clients, or the patients I work with, I'd say I would prescribe this in small amounts and often. People need to practice this regularly. And it's really important with these interventions that we practice them not only individually, but that we embed them into functional conversations and discourse, and that we provide a way of motivating people. And often that can be through the choice of vocabulary or the technology we use. We also have a way of helping people translate some of this practice into sentences. And just to wake you up a bit, I'm going to share a little bit about script training. So script training is something that has had high applicability for people with a particular type of non-fluent primary progressive aphasia, but we know it's really effective for people with logopenic variant aphasia too, and is again carries over to many other disorders, other types of dementia. And the idea here is, again, high dosage, personally relevant. You do lots of practice, and we draft topics, we draft scripts for people to practice. And I'm just popping up an example script. It might be a bit skewed to North London, just to wake you up a bit. But that's the whole aim of these, is that we're selecting personally relevant materials that people might speak about regularly. And you might hear people saying these kind of things in schools or pubs across North London. These are the kind of conversations that people will have in everyday life, topics they want to talk about, that we help them practice. And we know that this results in more fluency in conversation. And we also know from the research, it results in increased coherence in conversational discourse. I also wanted to touch, however, not only on these more impairment-based exercises, but on the more functional stuff. It's one thing us suggesting to people, go away and practice, but actually that's not everyone's cup of tea. And actually it doesn't help everybody. So we often find that it's much more useful to practice real life situations and ways of people enabling people, ways of providing ramps so that they can access conversations. And the current research literature in this field has really developed vastly over the last 10 years. And we know that this is a very heterogeneous field of interventions. Lots and lots of different things can be done. It's quite creative, but the key components across these interventions are that they tend to work best if we focus on building and expanding on an existing strategy somebody's already using, as they've developed a gradual, as their symptoms have gradually deteriorated, people have started working around them. And if we can enhance the strategies they've already developed, we're more likely to change and refine their behaviors, and working on these with a communication partner as well. The problem with this research evidence in comparison to what I've just presented to you is a lot of the work in this area is still in its development phase, and it lacks some robustness about it. It's not as rigorous as some of the other work done, however, still really important. And I'm going to give you some examples based on technology. And I've got my iPhone up here in the corner, I should say my tablet device. And what I'm going to give you some examples. There's some lovely studies done where people have used tablets and phones to take photos of shopping lists, so people can maintain their ability to go to the shops, either picture match, so taking photos of what's in their fridge, what they've run out of, so they can picture match or show people what they're asking for in shops. There's also some really lovely work been done on using photos of everyday activities to enhance conversations. And this is a photo of mine from the autumn, and you can guess what I was doing. But actually what we know is that sharing photos to support conversations results in more content in conversations between people, and actually increased effectiveness in those conversations, because we're providing them with a context for that person to have an interaction. And then finally, I wanted to touch on this because it's quite topical, but these high-tech devices can actually also provide opportunities for really exciting things like voice banking. So this is speech and language therapist Richard Cave, who was on BBC Breakfast recently, just last week, and he was talking about something called voice banking. And this is something we as speech language therapists have been doing for yonks. So voice banking can be anything from recording somebody's voice and embedding it in an app that then you can tap and it speaks for you. It can also be taking photos of family members, making videos of yourself interacting with people around you and looking at them and sharing them. So banking, these technology is providing a great opportunity for banking, voice banking, conversation banking, interaction banking. Just finally, in the last couple of minutes, I wanted to touch on conversation though. And I want to touch on this because I've got a more complicated graph here. And along the bottom, I've got a number of different therapeutic interventions, and up the side, the number of speech therapists who responded to a survey. And what I'm highlighting here is that when we actually asked speech therapists what they do in clinical practice, what they said was they don't actually do as much impairment-based work. So this pink represents what therapists do less often. What they tend to do a lot more of is what we call communication partner training. So, and that's what the green represents. So what we found is that speech and language therapists are actually finding that what people were wanting, what they're needing, what they're asking for, what addresses their needs, is working with the person and the people around them on conversation. And that's because conversation with people with PPA, with primary progressive aphasia or secondary progressive aphasia, is different, it's difficult, it's hard, impacts on relationships. And what we found is when we look at it, it's many of the difficulties in the relationship or conversation are held by the person, but often actually the partners are creating a lot of barriers. And I'm sure, as the clinicians in this audience can attest to, we see it all the time, that partners, family members, spouses will change the way they communicate with their loved ones with dementia, and often it's not that helpful. For example, they often start using test questions, which really change the relationship. And by a test question, I mean, for example, if I was sitting over breakfast with my family member and I started asking them to name all the foods on their plate, I'd be testing them. But I wouldn't routinely do that with my loved one. But we know that people with dementia, their loved ones do that with them. So what we know, and this has been my research, what my research has focused on, is developing conversation interventions. We know if we work with people and their loved ones, we can change their conversational style and adapt their conversation. And this is just an example of an intervention we developed to be delivered over a brief period, 4 sessions in the beginning stages of a person's disease journey. And we video record them before they have their intervention. And then we use the personalized video recordings of them to guide advice and strategy development. And what we've done is we've developed this as a package that sits as a freely available intervention on the UCL Extend website, which is the university where I work and do research. It's not there yet, but we're aiming to create an intervention that will be freely accessible so that speech and language therapists have more resources available to deliver these interventions. So this is my final slide. I also just wanted to flag that actually what I found often, over and above all this therapy I do, is actually connecting with other people has been one of the things that people yearn for, that they want to do to support them in managing and coping and developing strategies. And in part of my role, I co-run the PPA, the Primary Progressive Aphasia Support Group. And this is the type of thing we do. We run support groups, but we also create video recordings and we share people's experiences. And this is an example from a lady called Helen. And I would urge you to have a look or share it with the clients you're working with. And I have found that people have found it really useful to hear that there are other people experiencing the same things they are. So thank you very, very much for having me. I'm sorry that was a high-speed journey through the whole of speech and language therapy, but I hope it was useful, and thank you. And I hope it did justice, because I know there are a number of speech and language therapists in the audience today.